Good evening, and welcome to this program here on blackdoctor.org. I am Ellis Dean, the Director of Digital Programming and Production here at blackdoctor.org. And we are excited to be with you tonight for our this is our third installment of the Open Your Eyes series presented in partnership with our friends over at Genentech. We have Dr. Joe Coney is back with us again, and we are talking about diabetic retinopathy. And so if you have diabetes, even if you are pre-diabetic, you need to be paying attention to what's going on right now. If you have a family member that's diabetic, you need this information because this is all about your eyes and the impact that diabetes can have on your vision. And I think we said in the first program, we got to go back and watch it. We talked about all the different stages of diabetic retinopathy and how your eyes are just a wonderful, wonderful organ and how it can try to protect itself and correct itself. But if it has to do that too often, that's when we can have some serious problems, particularly when it comes to diabetes. And so tonight, we're really going to break down the eye, no pun intended, and we're going to go into some diagramming so you could actually see what the eye looks like. And this is why when we talked about in the previous show, there are 9 different specialties in medicine dedicated just to the eye. You're like, wow, you're like, it's just the eye? Yes, why? Well, you're going to learn that tonight. So before we get started, before we get to all of that, I got a couple of things I need for you to do for me. And number one is let us know where you're watching from. I see my girl Sherry is already in the building from Brooklyn, New York. So if you've got the opportunity, drop in the comment section. I'd like to know where people are watching us from. Number two, if you know somebody needs this information, whether they are diabetic, pre-diabetic, if you know somebody that's diabetic, if you know somebody that needs this information that might be having some problem with their vision, make sure you tag them or you share this program so they can get this information. And number three, if you have any questions, please drop those in the comment section. Thank you, Shannon from Dallas. Drop those questions in the comment section because we want to ask you. We've got one of the nation's top eye experts. He's a surgeon. So this is the time to ask questions. You've got a Black, culturally competent eye surgeon here to ask all your questions. So please, I love the people in South Louisiana. Okay, Sherry, you're tagging your folks. Thank you, Sherry, for tagging your friends and folks. So keep that happening, keep that going. So I want to say, welcome, good evening, Dr. Coney. How are you doing?
Ellis, I'm doing great, man. Thanks for having me again. I'm looking forward to the show tonight.
I see New Jersey's in the house. Keep tagging them, Sherry. We go make sure you are going to be the big winner for tonight. So first thing we want to do is we're going to break down, and Dr. Coney is going to do a great job in terms of breaking down the components of the eye. And then we're going to, in this description, we're going to start talking about where those problems occur. And then later on in the program, we're going to actually show you some actual photos of problematic eyes. And so really just kind of helping you understand so you'll be able to see the eye diagram. And then we'll show you some pictures of some problematic eyes. And then we'll also tell you about how to be your own best health advocate, right? So because a lot of times when you're seeing Dr. Coney, you're only seeing him 10, 15, 20 minutes tops. If you're having surgery, a little bit longer, but you don't want, a little bit longer. But the rest of that time, what happens to your eyes is up to you. It's about what you eat and the activities that you participate in. That's going to determine the health of your eyes. And so we're going to give you those tools and tips on how to keep your eyes protected, healthy, and well. So I have said enough. So we're going to bring up the eye. The structure of the eye, and you see all these different parts of it. And I promise you, I only knew about 50% of what I was looking at. I knew about the pupil and the cornea and the retina, but the rest of this, I have no idea what it is. Maybe the iris. But so, Dr. Cody, tell us what we're looking at so people can get an understanding of how their eye actually works.
So, Alice, I think in a very simplistic form, and we'll take the journey from the front to the back of the eye. The most simplistic form, I think the eye can be considered like a camera. You know, the camera that we used to have, not the camera on your cell phone. We're talking about the camera that actually had a film that you had to go to deliver something. And if back in the day when you had that film when you went to deliver it, not all the pictures were very clear. If the film was damaged from water or sunlight or exposure, or
Yeah.
let's say where you took the film to be to be developed, the images weren't very good.
Right.
So anything along that structure, whether it's the lens and the camera, which you can change for the different diopters, whether it's a film and a camera, or the processing center, all that has to be in line for you to get a good image.
Okay.
And the processing center for us is our brain. So our brain also have to be able to see things very well for you to have a good image. So the first thing you have is the cornea. The cornea people are familiar with, particularly if you wear a contact lens. It's the clear part of the eye. It's the very first part of the eye, and that's the part that you can actually touch. Then you have the skin around the eye. That's called the sclera. That's the white part. There's really
Okay.
two pieces of tissue that sit on top of the sclera, and there may be people out there that have inflammation and they have like conjunctivitis or scleritis. But these are the tissues of the eye that get inflamed. So if you have like inflammatory bowel disease, or if you have rheumatoid problems or sarcoid, these are all the things that get inflamed from when you have those sort of tissues. Then when you go into the eye, the front part of the eye, between the color part of the eye and the cornea, that's called the anterior chamber. And the anterior chamber is just a small opening where the fluid will circulate and go through a draining system called the trabecular meshwork. And those people tend to have problems with glaucoma. The fluid in the eye doesn't exit the eye very well, and so things build up. And what makes the fluid in the eye is that ciliary body. You see, there's a little notch there right behind the lens. We're going to talk about in a second. That's where the fluid is made, but the fluid is actually absorbed in the front part of the eye from the trabecular meshwork. The pupil is defined by the iris, which is the color part of the eye, whether it's blue, brown, or black, and there's that hole directly in the center, and that's the hole that gets bigger when the doctors dilate your eyes. They make them smaller or larger, depending on what medications that we give you. Then behind that you have the lens. The lens in the eye is just like the lens in the camera. You can change that lens to focus light onto the back of the retina, or really in the camera, it goes to the back of the film. So that's what, light kind of comes in the eye, and then it converges on that light, which actually puts it at a focal point, which allows us to see. That big orange part, that's the majority of the eye. That's called the vitreous cavity. And the vitreous cavity can have a whole host of problems, and that's the most common place we see bleeding in our diabetics. That whole cavity can get filled with blood. Mostly it's all water. Okay, it's an aging process. You have the vitreous humor, and as you get older, that gel in the eye, that vitreous humor, turns to water, and that's that gel that pulls off the back of the eye, where people always talk about those floaters, and that's where those floaters will occur. They cast a shadow on the back of the eye, which is then called the retina. The retina is just the lining of the back of that wall of the eye, and then you have the optic nerve. The optic nerve is what sends all that information to the brain. It's like the cable to the eye. And so that allows all the information to go to the brain. The brain will perceive it, and then you see an image. So everything has to be in working function in order for you to have a good quality image. Just one last thing about the lens is that the lens is also what they call the cataract. And the cataract is a normal aging process of the eye. And there's a lot of issues with the cataract, particularly if you're diabetic or you have inflammatory diseases, which is very common, particularly in our African American females. That's where the cataract will grow faster. Normal is aging, but if you have diabetes or inflammatory problems, that lens will age a little bit faster, and that it's removed once the cataract kind of matures.
Okay, so I got a couple of questions here. So number one is, so the pupil is an opening, and that opening gets wider if it needs more light. If you're in a dark room, that opening gets wider because it's trying to let in more light, and then it gets smaller when it's if you're in a bright area or bright room, that's when it gets smaller to let in less light for the eyes. Okay, so that's got that piece. Now, the cataract, what is a cataract? Is it just a growth that happens on the lens?
So I like to look at the cataract as another aging part of your body. So let's think about an onion or a tree bark. Once you cut that onion in half, there's rings around the onion. There's rings around that tree bark. Every year you'll get a different ring around the onion or a different ring on the tree bark. That tells you how old that onion is or how old that tree bark is. So every year the lens will get an extra ring. And then when you get about 40, 50, or 60, that the lens harden because of extra rings, the body can't accommodate as much, and so the ability to see up things up close, where you have glare when the light hits that lens, instead of being coming to a point, it diffracts the light. So people people complain of glare, particularly at night when they're driving.
Okay.
Contrast can be different because the lens changes colors. It's normally a clear structure, and then over time it gets a little greenish or a little orange or yellowish, and that cuts down the contrast that you can normally see in order to have a really clear image. And so these are the aging symptoms that you have. Our age, the things that we notice much is nearsightedness, or really, I'm sorry, really presbyopia. That's our ability to see up close. We need reading glasses because the lens is not as expandable. But as you get older, you can't accommodate as much, and you need a little help, and that's why we need a little bifocal.
Okay, so that's what I have on right now, and I noticed like I'm sitting, I stare at my computer pretty much all day, and my eyes tend to get tired. So I have these reading glasses, and it does help tremendously because of what you're talking about. And thank you, Sherry, for that. Sherry says this is really clear information for such a complicated organ such as the eye. And so she's already saying, thank you so much. And this is why we're doing this, because we want people to really kind of get an understanding. Not that you're going to walk around and break down. I mean, if this would be some great conversation at your next party, if you could tell people all the parts of an eye, but this is really for your own kind of understanding of what Dr. Coney is talking about and how complicated that whole vision process is, right? So we're talking about going from light to the lens, through the optic nerve, to the brain, and all of these different parts of it. And if there's a breakdown in any way, then that could have an impact on our vision. The beautiful thing, as we've talked about in previous episodes, is the eye does such a great job of trying to repair itself, trying to find different pathways to continue to maintain our vision. But this can be, a bad thing if it's doing it too much. If it's causing it to do it too much, then those auxiliary vessels that it creates can start to bleed. And we're going to show, we got a great picture of showing where the eye has had some bleeding in it. Okay, so the optic nerve goes into the brain, and then the brain perceives whatever we're watching, whatever we're looking at. So the macula, I've heard of, was it macular? What's the
So the macula is just a location in the back of the retina.
okay.
It's temporal to the optic nerve, so it sits on the outer side. And the macula is extremely important because that's important for all of your fine vision. That's important for your reading. It's important for your driving. It's also important for your depth perception. And there's many diseases that affects the macula. Most times you have distortion, blurred vision, sometimes double vision, things aren't as clear. You can even get a hole in your macula as well. There's a lot of diseases that you so in order to really evaluate the macula, you need an exam. And we have something called the OCT, which actually takes a three-dimensional look at the macula, because the macula is only about 250 microns thick. And because it's so thick, it's very difficult to look at small details when they're 10, 15, 30, 40 microns in size. So we have a machine that can take those different cuts to actually have a much better view.
Wow. Okay. So I've heard this a number of times because I'm a sports fanatic, and I've heard about like boxers getting a detached retina. Now, when I heard that, I was thinking that the retina was on the front part of the eye. And I see here from this diagram, it's more towards the back. So how does a retina become detached? And if it does become detached, what impact does that have on the eye?
So, Ellis, you're absolutely correct. Actually, it is in the front. So the retina is the whole lining of the back of the eye. What you're looking at on this scan here is a three-dimensional picture, and they're just highlighting the retina. But that whole wall goes all the way around, and it inserts right behind the lens at the ora serrata, which is not shown. It's almost, in this picture, if you see the ciliary body, it actually inserts somewhere in that area. So it's the lining of the whole retina. So when someone talks about a retinal tear in their eye, most times the symptoms are floaters, flashing lights. Sometimes as the gel ages, it pulls off the retina, and you can get It also can irritate a blood vessel, so you can get bleeding. But if there's a hole that occurs, that water, that gel that's been breaking down over years will go through that hole, and that separates the back of the retina from from the wall itself.
Okay.
That's called a retinal detachment. So it's kind of like wallpaper puckling as it comes off the back of the wall.
Okay.
So as
Okay.
a surgeon, what we do is that we go in, we take the vitreous out. That's that whole middle cavity of the gel. We find those holes, we seal them up with laser, and most times put a gas bubble in the eye because the gas bubble would keep the retina together as the retina heals.
Oh, wow. Okay. Okay. So we've already got some questions coming in. So, we've answered this before, but we're going to make sure in previous shows, we're going to make sure we're going to keep banging this drum so people get it. So Sherry's asking, how often should a healthy adult have their eyes examined? And how often should an adult with diabetes have their eyes examined?
So, as you age, you always want to have all your doctors kind of lined up just for routine health. So if you have no medical problems and you wear glasses, you're going to probably go in every couple of years because your prescription will change. So that's probably normal. If you don't have any problems whatsoever, every 5 years are probably okay. If you have a history of glaucoma, which is very common in African Americans, you definitely want to have your eyes examined every 2 to 3 years. Let them know. I think the most important thing, you let the doctor know that you have a family history of glaucoma.
Okay.
Oftentimes, we only think of high pressure being the major risk factor for glaucoma, but people don't know that African Americans tend to have a thinner cornea. So the pressure sometimes that we check in the office may be falsely low. So they would go. So we see people going to these health fairs and they're doing glaucoma screenings and their pressures are normal. But indeed, your pressure can also be normal and you can have glaucoma. And so it takes a little bit more than just a pressure check. And that's the important part of going in to see your doctor and letting them know that my mom, my dad, my brother, or sister have glaucoma because your risk is much higher. Once you have diabetes, if you have type 2 diabetes, we do recommend an exam once they're diagnosed, because the early stages of diabetes, there are no signs or symptoms. There's no vision loss. Okay. But oftentimes, people have diabetes much longer than they are aware of, and the damage is already starting. If you're a type 1 diabetic, it's very uncommon to get changes in the eyes at an early age. So we always talk about around adolescent age is probably the most important part for them. And then if they don't have any diabetes in their eye, an annual appointment is recommended. And if you have diabetes, depending on your stage, we want to make sure that you follow up with that staging criteria, because we know by the different stages how often an eye may progress to something that is sight threatening.
Oh, wow. Okay. And I just want to point out something that you saw here, and this is why this is a great program, is Dr. Coney just pointed out something very, very subtly different in terms of Black patients when it comes to glaucoma versus mainstream or white patients. And so if we do go to those things, we need to understand that you need to see a specialist that understands that difference. So particularly if you have a family history of glaucoma, so they can kind of watch you a little bit earlier and not just say something is normal and then send you on your way and you develop glaucoma because your readings were normal, and they don't understand that there is a difference in how those readings land in African Americans. So I think that's a very excellent point that you just made. And Sherry, she just put the thumbs up and said, wow, glaucoma in African Americans, absolutely. So we've got some great questions coming in. Kevin is asking, what if even with glasses, your vision is a little blurred? Is that something that they should go to their optometrist to get their prescription redone, or is that a signal of a more serious problem?
So Ellis, that's a very difficult question, because blurred vision is a common thing for all of our medical problems, right? So I think that if you're not refractive to 20/20, I think that you should see someone and find out why you're not 20/20. Is it because you were born with a weaker eye, and that's called amblyopia? Some people can have a normal eye, but they never were 20/20 when they were a child. So glasses are not going to refract them, where their eyes misaligned. And so one eye didn't mature as well as the other eye. So it could be something congenital, or it could be something early cataracts. It could be inflammation. It could be a problem with the retina. I mean, it's a lot of different things which can deteriorate the vision. It could be uncorrected astigmatism. Maybe the glasses are just not made correctly. So if you get a pair of glasses and you see better without your glasses than you put them on, your doctor should really recheck that. You should check the astigmatism and make sure that the prescription they wrote on the page is the same thing that is grounded up in those glasses. So it could be something very simple, or yes, it could be something medically that needs to be addressed.
So, Kevin, I hope that answered your question. Thank you for that. And so I would say go back to, or maybe even make an appointment with an ophthalmologist if you're not seeing one already, and have them do a full kind of dilating and full eye workup, because, and there's a difference. We did this last week. We did a show with our partners at the CVEA and the NEI, and we talked about the difference between ophthalmology and optometry. And even though they are working together as a team, there is a difference in the professions. And so we got to make sure Dr. Coney is an ophthalmologist and he is an eye surgeon, where optometrists kind of deal primarily with glasses and contact lenses and things of that nature. I'm oversimplifying, but that's just there's a difference there. Some other questions here. I had a stroke. Somebody saying they had a stroke and now my vision has changed. Is that would stroke cause a vision change?
And so that goes back to talking about the different compartments, and then that third part, which is the processing center, which means the brain. So
Okay.
anytime you have any kind of brain problem, where if I saw a lady today, she actually had a traumatic fall, and she passed out for a little bit. She had a concussion, and her vision was down 4 lines. And it takes some time before that vision to actually reoccur. There was no bleeding on the brain, but she probably had a little bit of swelling that was not detected. So any type of strokes in the brain, any type of lesions, you have seizure disorders. There's even some medications that can throw off your vision too, because there are some medications that crosses the blood brain barrier. A lot of times we're on like antidepressants or antipsychotics. Those are some things that can also change your vision. But strokes, clearly, the big thing about strokes is that it also can take away some of your visual field. And most time it's the same size. So, it's either both of the right or both of the left, or just a quadrant, depending on, the part of the brain. The interesting thing about the brain is that the brain is very specific on what it controls. And so if you block off a particular blood vessel, your doctor, just by doing a visual field test, can almost localize where the stroke was. Because they know what part of the brain controls what part of the visual field.
Wow. Okay. All right. So that's a whole other show. All right. We've got somebody who wants to get an understanding of astigmatism, right? Because we hear that term a lot. And a lot of times we just kind of act like we know what we're talking about. I know I do that. I'm speaking for myself. Somebody says something, they say, "Oh, you got astigmatism." I'm like, "Oh yeah, okay, yeah." And I walk around, I have no idea what they're talking about. So it kind of help people understand what an astigmatism is, and with our diagram, if it's in a particular area that the eye that it impacts.
So astigmatism normally comes from the cornea. The majority of the time, I'll make this very simple. The cornea is just irregular. It's not a smooth shape. And so astigmatism, so glasses or a contact lens, we have different things that we call axes. So this is a up and down, 90 degree, and this is 180 degree, and then everything's in between. We can map out exactly where the astigmatism is, and then try to correct that with glasses so things aren't wavy or distorted or out of focus. Okay. So one thing is focus on how the length of what you need to see. And the other part is trying to smooth out the cornea with a pair of prisms to allow things to be more in focus.
Okay. All right. Keep your questions coming. We're gonna shift, and we're gonna show some of the pictures of actual eyes. So this is a diagram. This is like a 3-dimensional cutout diagram of an eye. But now we're going to see some real pictures of some eyes. So keep your questions coming in. If you're just joining us, we are here with Open Your Eyes with Dr. Coney. This is part of our 6-part series on eye health, specifically talking about diabetic retinopathy in partnership with our friends at Genentech. And so tonight we're really breaking down the eye, and we're talking about the areas that are impacted, specifically about those conditions that are disproportionately impact our population, particularly diabetic retinopathy. And we talked a little bit about some cataracts, and we talked about glaucoma, because those are big three when it comes to Black folks and eye illnesses. So keep your questions coming in. So all right, let's start with some of these pictures here. And I was getting these pictures. I was like, okay, so let's start with the normal. We're going to show what a normal human eye looks like. So help us understand what we're looking at here, Dr. Coney.
So this photo, it's a photograph of the right eye, and it's really here to depict what a normal photograph looks like. That little thing in the middle, sorry I don't have a pointer, but where the vessels are coming out, that's the optic nerve. That's where the brain, it's actually part of your brain. That's where the brain terminates. That's where it ends. And all those vessels come from the back, and then they spread out. Okay. That little area directly center where it looks a little dark, that's the macula. So the macula is really defined by that big vessel and smaller vessel around that area. And the thing in the middle, that's the center of the macula, or the fovea. And when we talk about diabetes or macular holes or disease of the macula, this is typically where we're talking about. The outside part of the retina, that's where the detachments occur. Those holes happen on the outside part. So one of the other symptoms that we didn't talk about is like a shade or a curtain coming down over your eye. And so the retina will fall apart, and we'll have to put that retina back up depending on where it falls apart. That we call the peripheral retina. That's where the diseases like sickle cell disease happen, or things like lupus or sarcoid. They get abnormal blood vessels most times in the outside part of the eye. And the thing you're looking at between the front and the back, that's called the vitreous cavity. And this is a clear photograph. If there was an inflammation in that cavity, the view of that photograph would be very blurred. If the cataract was bad, it would be very blurred, but something has to block your view of seeing the back of the retina.
Okay. So this is basically a normal, healthy eye, a picture of a normal, healthy eye. And so that macula, and I'm sure many people have heard that, the terminology macular degeneration, that's kind of part of that when we had that issues with the macular. So this is what a normal eye looks like. We're going to bring up another normal picture because we're going to kind of start, and we're going to work our way into some problematic eyes. So help us understand what we're looking at here, Dr. Coney.
So this is that OCT I mentioned earlier, which helps me to look at the thickness of the center of the retina and if there's a problem. That little depression in the middle, that is the very center part of the macula. This is a very healthy picture. And if they look at very closely at this photograph, there's different colors and different bands. That's the 9 different levels of the retina itself. And so oftentimes when there's problems, you have fluid either within that space or underneath that space.
Okay. So when I show this picture.
So this is a photograph which shows swelling of the retina or macular edema. This person has diabetes, and those little cavitations you see, that's the swelling that is causing this person to have blurred vision, because that focal point you saw in the previous picture is no longer there. So they're distorted, they're blurred. But the vision in this patient could be very good. There's not a strong correlation between how a picture looks and how a person sees, because sometimes you can have fluid and the vision can be really good, or it can be really, really bad.
Okay. But I'm just gonna go back to the normal. You see how like the normal, there's got that slight indentation. It looks, I mean, it's almost a smooth picture, whereas when we have this diabetic, a person that's diabetic, you see how different. Now, to Dr. Coney's point, at this point, this person may or may not have impairment in their vision, but there is some issues in terms of how the eye is structured and how it's built versus like this normal picture and this one.
So the eyes could be very tolerant. So people can have a slow decrease in vision, let's say from 2020 to 2030, or maybe 2040. You may not be so aware of it, but 2040 is an important number because that's when you start to have problems with driving. And oftentimes when people come in, they can have swelling for a number of years, but didn't have the vision loss. So now it's just starting to catch up. And that's the reason why if we catch them before the vision drops, we can preserve their vision, and they can see a lot longer than losing their vision over time.
Okay, so I heard something that was very depressing when we did our show last week, and they said we're all going to get cataracts. Is that true?
Yes. So cataracts is an aging problem. That's the reason why everyone will need their bifocals, Ellis. That's why you need those bifocals. You are, I hate to say it, my brother, but you also are developing a cataract. It's not ready for surgery. You can be corrected, but once the glasses can't correct you, then you need cataracts. But we all will have those cataracts taken off at some point.
Oh wow. Okay. All right.
But that's
Too
okay, because guess what? We put all your medicine in your lens, and one day you're out of your glasses. And that's the greatest thing about cataract surgery. No more glasses for some people.
Oh yeah, yeah. No, that's wonderful. That is wonderful. All right. So I think I've got the right photo. The next photo. All right.
So this is a photograph where someone is coming in and they actually have bleeding in the eye, and there's abnormal blood vessels. So the small things are arteries, and these big things are veins. But there's a collection of abnormal blood vessels also on the optic nerve. And this is a person that also have diabetes, where they probably didn't have any vision loss, and over time, because it wasn't caught, this person now has abnormal blood vessels and bleeding. For the same reason you said earlier, the body is trying to compensate for what is lacking, which is really oxygen.
Okay. Okay. So like that. So we're seeing. So they've developed some auxiliary blood vessels to compensate, and now they're having some bleeding. May or may not have impacted their vision to this point, but if this is to continue unchecked, they could develop some significant vision problems in the future over time.
Yes.
Okay. All right. So now we're going down that road. We're going down that road. Okay.
So this could have been that same person you just showed me.
Okay.
Now this is a fluorescent angiogram. This is the reason why I love what I do. The photographs can show one thing, but the fluorescent angiogram, I think, is critical. So people have to understand, once they go to a retina specialist and they're diagnosed with diabetes, there are some things that the doctor wants to take. And one of them is putting a little dye in the veins. It's called the fluorescent angiogram. It's like doing a catheterization for the heart to show where the blockages are. Mm-hmm. Here we can see where the blockages are. We can see how that dye flows through the veins and arteries. We also can see the development of abnormal blood vessels. So in this picture here, this is a picture of the right eye, and everything you see in this picture that's white is abnormal. The dye that's been put through the veins should stay in the veins, in the arteries. It should not be leaking out. So this is an eye that has intense leakage around the outer part of the eye because there's poor circulation around the whole eye. There's also leakage around the optic nerve. So this person has severe diabetic retinopathy with severe neovascularization and adenal vessels on the nerve. If you look on the further outside of the eye, those little black spots there, those are gap zones or what we call ischemic tissue, where there's no circulation to that area. And the blood vessels tend to grow in areas between good circulation and bad circulation. So it's trying to compensate for that zone that's really struggling.
Okay. Wow. This is. I mean, I'm sorry. I'm kind of geeking out a little bit here. So I'm just like, it's very, very fascinating to see. And now when we're talking about diabetic retinopathy for our audience, now they can actually see what it looks like. So we're seeing the actual process of when we're talking about those blood vessels leaking blood. Now we see that because they put the dye in, and where that white is that dye leaking out, right? And so that's not supposed to happen.
So, Alice, I would point out one important thing about these photographs. Mm-hmm. The great thing about our ancillary tests is that when people see a picture of their eye, they see the abnormal blood vessels, they see the leakage. Oftentimes, we're the ones that get them to stop smoking, to get their blood pressure, control, watch their diet, increase their activity, right. Because they don't realize how bad their eyes really are. So this is that aha moment.
Yeah.
And so I use this as a teaching tool, but then I try to, because you don't want to put in so much tough information on a day, right? Because it could be overwhelming. Right. I try to then let them know where we can go by treating this, particularly if their vision is not affected. But we really have to be very aggressive with these eyes. And I'm hoping that in a year or so, their vision is the same and all the retinopathy is stable.
Absolutely. That is the goal. Okay. So we're moving on down the line. What are we looking at here?
So this was actually that patient the first person you showed me that showed all the intense vessels on the nerve. You can't tell here, but this eye has been lasered. All the retinopathy is quiet. There's no leaking blood vessels in this eye. And this person is still 20/20 and doing very well. This was from that first person that didn't realize that they had any abnormal problems going on.
Is that like from this one?
No.
Okay.
Show me the next one. That one.
That one.
It's a different photograph taken from a different image, but it's the same eye.
Okay. Okay. So, but this is after the eye has been treated.
Yes.
Okay. Oh, perfect. All right.
It's a lower power. So this is a wider photograph. So when you take a wider photograph, you lose the power to really focus on the middle of the eye. But what you don't see here is those abnormal blood vessels that's around the optic nerve.
Yeah, much cleaner look there. And then, all right. So what are we looking at here?
So this is the same person actually. It's just
Okay.
their other eye. And unfortunately, this is the more advanced form where the blood vessels now has developed scar tissue. We call this tractional retinal detachment. This person has bleeding on the outside part. He has scar tissue in the middle. You can't even see the nerve. The nerve is completely obliterated by the scar tissue. This person is scheduled for surgery in about 2 weeks.
Okay. And has this person started to have vision loss?
This eye unfortunately has counting fingers vision. So what we decided to do is stabilize the first eye first before proceeding with this eye, because they weren't quite sure if they wanted surgery in his eye that didn't see, and they know the prognosis may not be very good. And I was okay with that. So it took me 3 months to really stabilize the other eye. And now that we stabilized that, this picture was taken today. We have now decided to proceed to see if there's any salvageable vision in this eye. But unfortunately, lasers or injections are not beneficial for this person. It's going to be surgery.
Oh, okay. Wow, that was, I mean, really, it really kind of breaks down, and we can see what it looks like on the inside. And you're right, that's that aha moment that we're moving into the second part of this conversation. So we talked about the eye diagram, and we've talked about, and we've showed some live pictures of what eyes to look like. So let's talk about the behaviors. What can we do? What can people do to be their own best advocate? Because as we talked about at the top of the program, they only see you a small, very small portion of the time, even when they have surgery. What should they be doing in their life in order to make sure that their vision remains as healthy as possible?
Ellis, I told you this on I think the first show, the second show, and I think it's worth keep saying it over and over again. It's the ABCs of diabetes. Okay. keeping that A1C level under control, and for most people, less than 7. They need to talk to their doctor to figure out, doc, what is my endpoint? Where do you want me to be? What's my range? And you and your physician have that discussion and try to find that target A1C just for you. Your blood pressure. People don't realize that even if your sugars are well controlled, blood pressure can still make the diabetes worse. So controlling that blood pressure, for me, blood pressure less than 140/80 is going to always be good. Normal is 120/80. So just by keeping that pressure lower, you're keeping that stress off the back of the eye. And then watching the other factors that can contribute to worsening retinopathy, things like your cholesterol, your diet, your exercise. Smoking is really big, because what you saw in those pictures, that those vessels are really small, particularly the arteries when it comes to the eye.
Yes.
And so those small arteries, once they already have a lack of circulation or not enough blood supply to that organ, the toxic elements from the smoking would damage that. And smoking, we know, is a progenitor for atherosclerosis, which is hardening of the arteries. So not only do you get hardening of the arteries in your heart and your legs, but you also can actually get them in your eye as well. We see high blood pressure changes in the eye. We can see strokes in the eyes. All these things can happen, and it's all because you have a bad circulation. So I think those are the most important things to talk to your physician about. Whether you need to talk to a dietitian. Everyone diet is different. And as a retina surgeon, I don't get into the weeds on what you should be eating or not be eating. Trust me, I'm probably not the healthiest person out there when it comes to making sure that I'm eating properly. But when you have a problem, you want to make sure you're doing that. And I think a nutritionist for those people are important. There's a lot of information even about overall wellness and what antioxidant foods you should be having. I talked to a friend today, and he was telling me he was seeing a person that was finding out what his body reacts to in terms of inflammation. And his wife, it was like she loves pineapples. Well, the doctor was like, well, you should be eating pineapples because for your body, it may increase inflammation. From him, it was eggs and milk. And he went through this testing to find this out. And he's been doing this for a year. And he said he's a type 1 diabetic. His diabetes is extremely controlled. He's trimmed down, and man, he's doing great. And it's just by changing his diet. And he got this from a nutritionist about things to do and not to do. So I think that may be helpful for some people, particularly if you have different inflammatory problems.
Well, we know inflammation, that's the dirty word when it comes to any kind of, when we talk about conditions. And we've got some programming here on blackdoctor.org. On Thursday nights, we do a show called Veganish. And we talk about eating a more plant-based diet because we understand that in a general sense, having a more plant-based diet is healthier. And it's what Dr. Coney is talking about is like, okay, going it out to that next level, which is, okay, which foods, which plants might be best for you, because you would think pineapple is good for you, but it may not be good for you just based on your composition. And so, but we're just talking about it in a general sense. So this, over the next couple of weeks, we've been talking about the different color foods. So last week we did red, and we talked about all the red foods and what red foods and the impact they have on your body. And then this week we're talking about purple foods. So we're going to be talking about the color purple and how, no pun intended, how the color purple and the purple foods impacts the body in a healthy way. And so really what we're talking about in terms of diet, and I love that you put it down in ABC. So A1C, blood pressure, and then C is like cholesterol or those other factors. Smoking is just, we know smoking is bad, right? Like once the industry got their hands slapped and they had to start releasing the data that they've had for all those years, we realized smoking is not good for you. Because when we looked at those pictures, those are blown up pictures of the eyes, and see how small those vessels are. And we know that smoking constricts those blood vessels, makes it harder for blood to flow through. And we can see what can happen to the eyes. And that's very important. Some great. So there's a question here from Nadia. She asked it earlier. She's asking, what causes dry eyes?
So Nadia, that's a phenomenal question. And unfortunately, dry eyes affects more people than not. And we're just not aware of it. So dry eyes could be something medical, or it can be something structural, or it can be part of your aging process. As you age, your body tends to dry out. I mean, the women on this call, I don't have to tell them about drying out. Okay, it's the same type of tissue, as we have in other places. So the lubrication around the eyes dry out, particularly when you go through that menopause state, and the glands just don't make enough water. So that's number one. There can be inflammation around the eyelids, or there can be different oil secretions. So it can be a lid problem. A lot of things we see with our younger people are more medical problems. Particularly thyroid is one of the bigger problems with dry eyes. Most times they have more prominent eyes. The way that the thyroid affects the eyes, it deposits things in the muscles. It can damage organs. Sarcoid, also very common in the African American community. It actually affects the lacrimal gland sometimes, and that's where some of your tears kind of come from. So, with dry eyes is a very hard topic. That could be an hour in itself. I think the most important thing is to figure out why you have dry eyes. The symptoms of dry eyes are mostly irritation, redness, excessive tearing. People don't realize, well, doc, how can I be dry when I have all these tears coming down my face? Well, that's a response that your body is giving you, saying that, hey, my eyes are dry. The brain is very good, but it cannot keep everything stable as it needs to. So for example, if you twist your ankle is just going to swell. all your brain says, hey, there's pain in my ankle, and I'll just send cells there to protect it. But it overprotects it, and that's why the swelling happens. In
Hmm.
the eye, it's a reflex. When the eye is dry, it just sends tears. It just can't give you just what you need. It gives you overabundance of tears, and then those tears are running off your face. So excess of tearing is a sign of dry eyes.
Hmm.
So sometimes you can use artificial tears. Sometimes you may need um, drops, and sometimes the drops you're taking, like glaucoma drops or medical drops, can also dry out your eyes as well.
Oh wow, yeah, that's interesting because I wouldn't think that, but now it makes perfect sense. Your body just says, okay, I got dry eyes, I'm just going to keep making tears and sending tears, and so so you think, oh, I'm good. No, no, you should go get it checked out. There's a question: should we eat according to our blood type?
That's it. That one I don't know. I don't know if blood type has anything to do with what you eat.
Right.
As a retina surgeon, that's something normally I'm not concentrating on.
Yeah.
But overall, general health, I think, is really, really important. I do think genetics is important for what we eat and how we handle uh, certain foods. Um, I think that's important.
Yeah, I will say this. I would say I think it's Nai. I hope I'm pronouncing your name right. I would say go see an allergy specialist because there's some foods that might cause you to have an allergic reaction, and that allergic reaction is not due to your blood type, but it could just be something that's impacting you. So I realize there are certain foods, certain things that I eat that even though I might like them per se, it's not doing my body good. And having any type of allergic reaction to some foods is not a good thing, no matter how much you like it. And so I would say, go see an allergist and see if there is an unknown food allergy that you might not, know about. And then maybe that nutritionist that Dr. Coney talked about, or seeing a dietitian, they kind of talk about those things that might be impacting your body negatively. Like some people can drink milk and not have any, lactose intolerance problems, and some people can drink milk and their stomach does backflips. And so it's just the way your body is processing certain foods and certain ingredients, certain parts of foods. So the more understanding you can get about how you work, the better you'll have in terms of having a healthier diet that's going to be more beneficial to you as you age, particularly as you age. Um, so Pamela's asking a question: what causes dark rings around the eyes? I'm not sure that is that something that y'all
Yeah,
deal with?
actually, it is. Dark rings around the eye can be something pathological if you have too much. There are certain things where your body can't tolerate copper, for example,
Okay.
or different. So they get deposited around the eyes, and so that could be an issue. Sometimes it's just aging, right? I mean,
Hmm.
but it also could be that something's going on with your metabolism, with how you metabolize certain things. Copper gets deposited also in your heart and around your eyes, and so and even in your liver, they can cause liver problems. So sometimes it could be a pathological problem. Most times it's not, but again, I think that's the reason why you go in and you talk to your doctor and you have these discussions. Say, doc, what can this be? What all of um, what is the differential for this problem that I have, no matter what the problems are. And that helps have the conversation and let the doctor talk.
Yeah.
I think the best way to get information is have an open-ended discussion, or have to give an open-ended question, and then let them talk in order for you to have a discussion.
Yes.
Um, and make sure you have that information. I think the biggest things that, and if you have a lot of problems, you can't get all these things out, but the next time you come in, then you can talk about some other things. So you want to prioritize what's important.
Right.
Sometimes now they have these portals and you can talk to doctors or their assistants through these portals. That may be another way to get all the information you need as well, that you can't get into that 15-20 minute exam.
Absolutely. I think you're making an excellent point there. And so one of the things, and that was going to be the last question that I asked for you tonight. What are some questions that if somebody does make that appointment to go see an ophthalmologist, or even that first, foray into, if they're starting to have some blurriness or whatever, what are those series of questions that they should be asking in order to be their own best advocate when it comes to their eye health?
Again, I think the most important thing is just have that have that open question and listen to them talk. Make sure that the symptoms that you ask them that they are addressed and say, well, what is your thought process about these floaters or my blur vision or the pain in my eye or this bump on my lid or whatever the question may be. And then, let's tie this all back to diabetes. If your blurriness is from your diabetes, what stage of my diabetes do I have, and what's the probability of my disease progressing in the next 1 to 3 years without therapy? What are my options for therapy? If this was you, would that be the same medication or the same route that you would do if it was yourself or your mom or another loved one? I think those conversations are okay to have, even with surgery, because the doctor may give you an option, laser versus injection or versus surgery. Well, doctor, this is your eye. What would you do? And so that's a different question, because sometimes we look at data to help guide us to where we need to go. That's why we have clinical trials. It's a footprint to help us navigate through difficult situations to hopefully come out with a good outcome. But sometimes can you skip A and B and go right to C? Absolutely. And so these are the things that you want to have with those physicians. But I think just letting them talk, open that question up, and then making sure that you feel comfortable with those questions.
Yeah.
Or make sure that the answers to your questions are suffice for you.
And I would just add, two quick things to that. Number one, if you're unsure or what's going on, take somebody with you, right? Take an accountability partner that can sit in there and hear what the doctor is saying as well, right? So if you've got a spouse, take your spouse with you, because your spouse has probably heard all your complaints, right? Your spouse has heard it when it first started happening, and it might be, depending if you're like me, it might be 2 or 3 months of complaining before I actually go see the doctor.
Don't get in trouble, Ellis. Don't get in trouble now.
I'm just keeping it real. My wife has heard enough of my complaints. Oh, my shoulder. Oh, my this. Oh, my back. And she finally says, well, go see the doctor, right? So take your spouse with you. Also, or if you can't do that, pen and a pad, right? So that way, when the doctor is giving you some instructions, you write it down, because sometimes that processing, you might need to read it a little bit later on. All of us process differently. Sometimes that process of actually writing it down helps it crystallize in your brain more, have it there. And also that sending the message just, to the doctor that you're serious about what's going on, right? If you start taking notes when they start talking, as Dr. Coney said, you ask an opening question, doctor starts talking, and you start taking notes, that's sending a sign that, hey, that you're serious about what's going on, and you're more likely going to follow up because you have it written down and it becomes part of your routine versus just you're there to try to fix something, right? Because what we're trying to do is create something that is going to be in perpetuity and not just a short-term Band-Aid fix.
I think it's also important for them to make sure they send the referring doctor a letter of what's went on for that appointment. A lot of times I see patients and their doctors are managing their sugars, and they're pretty happy on their management, but I'm looking in their eyes and, hey, your eyes are getting worse. So I send a courtesy letter. I let them know that their retinopathy is getting worse and they need to be under tighter control. But if the medical doctor or your internal medicine doctor is not aware that you're getting worse, if one hand is not talking to the other hand, it never gets resolved. And so you need to have your team all on the same page and have them to communicate. And it's not a bad thing to even have them to send a letter to you. So whatever letter it's in your doctor, say, hey, can I have a copy of my letter? You can start your own file. And just stand on top of everything, I think is the most important thing.
Yeah, and I think electronic medicine and electronic records has really helped in that process, because you can go in, log in, and see what the doctor says, and so you can go back, even if you forget, you can go back in, see the notes and what the treatment plan was, and so then that way you can either print that out or pull it up and show it to your next doctor, so they're all on the same page. And so I think that process has helped a significant amount in terms of communication versus the way it was back in the day. It was it was a little bit more tedious to do it, but now we've got the ability. And my point of this whole questioning and having this part of this conversation is, I want our audience to understand how much control you actually have in this process. Yes, you might have diabetic retinopathy, right? You might have some retinopathy forming as a result of your diabetes, but you still have control. over this process. You still have control over what happens. You still have control of you have control of your diet, of other activities. If you're smoking, you can stop smoking. You can cessate your drinking. You can lower your cholesterol. You can make sure that your high blood pressure is under control. There's so many different things that you have control over that's outside of what Dr. Coney can do, that the more you take control of that, the better your outcomes are, versus you just trying to say, Dr. Coney, I'm coming here to fix me. So, I love it.
Great.
That's my soapbox, and that's what we're gonna end right there. I see Renee. That's an interesting question. She says, your thoughts on toric cataract lens replacement.
All right, so I'll end there real quick. So I think this is a great discussion, and this is a discussion that my friends' parents call me about on a daily basis.
Okay.
So there are something called premium lenses or premium IOLs. This is a little bit different than regular cataract surgery. And this is for people that really want not to wear glasses. So oftentimes in cataracts, they will put a lens. Well, if we take something away from you, we have to give you something. So if we take your ability away to focus light on the back of the retina, we need to give you something so you can focus that light. So that's the IOL lens. Typically, an IOL lens is fixed at a distance. The toric lens is good for distance, intermediate, and also near. It's a customizable lens. I like those lenses a lot. I think the most important thing is when you have your consultation, you want to see, ask the doctor, what are my barriers to having this lens? Do you foresee anything in my future that may say this would not be a good lens for me? I don't think this lens is a good lens for a diabetic patient who has diabetic retinopathy, for example, because once they develop diabetes, those little spherical things that we see in the lens, the patients cannot see very well. They're more blurred. Anyone that has any scar tissue on the back of their macula, if they had a history of retinal detachment, if they, any kind of disease process in the back of the eye, I think may limit them from maximizing their vision potential, and they may not be as happy with those lenses.
Yeah. Well, I had no idea. So as you can see, our audience is on top of things. I mean, they got real specific really quickly. So I want to thank Dr. Coney for joining us. This was a fascinating discussion. We're going to replay this tomorrow morning, so we're going to get a chance of people that, if you might not be on social media tonight, you might be watching something else, you can watch it, and you can tell your friends, hey, we're going to play it again tomorrow morning. About this, and just a wonderful discussion, breaking down what the eye looks like. We saw some great pictures of actual eyes, in healthy eyes, as well as eyes that are suffering from diabetic retinopathy. And then we talked about the things that you can do, the control that you have over your eye health and your vision. So really follow those ABCs. That makes sure your A1C is fine, and making sure your blood pressure is under control and that cholesterol is down, as well as other activities that you have control over, how much you exercise, what you put into your body, and smoking and other activities like that you have control over. So it's all about you taking control and being in the driver's seat of your health. And so thank you, Dr. Coney, and thank you to our friends over at Genentech for partnering with us on this discussion. And we look forward to the next time when we have here on Open Your Eyes on blackdoctor.org. Thank you, and y'all have a good evening.
Thanks, Ellis.